Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Alex. How are you doing today?
Oh man, it's super fun to continue forward on this tangent that you've got here within PFC, doing some scientific article review. I hope it is of benefit to the community. I haven't heard much, but we're going to keep doing this till people tell us to stop. But I would be even more excited if they'd tell us what to do differently.
Yeah, absolutely. Luckily, the tens of people that listen, maybe one of them will get around to saying something. But onto this podcast. So I read a post on hyperkalemia and that calcium is useless, which of course set my hair on fire, and I decided I'm going to dig into what the hell this guy is talking about. So I downloaded the paper that he was referencing and I read through it. And then I got a sneaking suspicion, so I wanted to look at the references that they used for their meta-analysis, and I read that paper. And the paper that they're referencing does not at all seem to agree with the things that these people said about my favorite element, which is calcium. So that's how I got to this question. I would like to kind of go through, research how weird, crazy things are going to be said definitely on social media, and sometimes even in research papers. How does one go about settling? Should I immediately throw away the thing that this person says doesn't work, or how does one go about this?
Yeah, absolutely. And for those out there who haven't had the privilege of listening to another fantastic podcast that's pretty high level, The Skeptic's Guide to Emergency Medicine is by a really great professional educator out of Canada. And he really likes to foot stomp this issue that the knowledge to translation window of when we know something to be true, quote unquote, versus when we actually adopt it into clinical practice in medicine typically ends up being about 17 years. And I think that really comes from this vacillation that we see in practice, where somebody maybe gets an inkling that something might be helpful or not helpful, and it gets tested and we get a conclusion, and then it gets tested again and we get a different conclusion, and then it might get tested in a bigger group and we get a different conclusion, and finally we can arrive at a consensus. But your point is incredibly well taken, and I'm certainly spending more time thinking about this as well. Because we do end up, when we go out and do some training and things like that, guys give us these very black and white answers because they have learned from the schoolhouses these very black and white solutions to problems. But as I learned years ago from a really gifted trauma surgeon who was a jerk, but was really good at his job, he said, young surgeons know the rules and old surgeons know the exceptions to the rules. So when we hear folks give these very black and white approaches to medicine, like the posting from the physician scientist you mentioned, that really harkens to me that that's somebody who doesn't actually have a ton of clinical experience, because the world of medicine is quite gray. And so I really appreciate you bringing that up to the audience out there to spend more time thinking about how gray medicine is. And as we teach the med students, 50% of what we teach them is going to be wrong. We just don't know what 50% it is. And so when folks, again, draw this line in the sand about things, it kind of raises the hackles that they may not be as expert in their field as they like to think. So here's the article that you found for us. What is it about this particular article that was of interest to you?
So, if it was fentanyl versus sufentanil, I would probably not even bother, because it doesn't apply to me, nor do I really care. But when it's something that's like an emergency type drug, especially when it's really the only rescue drug that we have, at least pre-hospital. What happens in a hospital? They have wave magic wands and things happen. It's amazing. I don't have that. But I do am able to get calcium, and when I see something that can cause somebody to doubt, does it work or not? That's something that will make me dig in and find out, is this something to is this something that should be acted on in any way? And so that's why I went through and read this paper, and then I went through the references for that paper, specifically the ones that the author said that I got this conclusion from this paper. That's what made me dig in. And so just for the simple fact of if it's making me question what's going on, I'm sure if anybody else were to read it, they might come to the same conclusion. Are they willing to put in the work, though, or are they just going to give up? I don't know. So I decided I would like to talk to somebody about this.
Yeah, and it's so awesome to hear you say that you read an interesting scientific paper and then you actually went and read the references from that paper. That's pretty next level. And I wish we all had the time and interest in doing that. But unfortunately, I think we know that folks in the community tend to stay pretty busy and task saturated. But I'll just foot stomp you on that, because there have been so many times when I'm reviewing an article that gets submitted to a journal, and I'll do exactly what you did and find out that whoever submitted an article to us maybe took what I would generously call liberties with the conclusions of the articles that they cited, i.e. fraud. And even including some of the PhD dissertations that we review as faculty, the same thing ends up coming true. And that is certainly not a good way to start your academic career. But it is incredibly insightful how often that ends up happening, that someone posting on social media posts perhaps will make accusations about conclusions from references that are in no way, shape, or form true. And that is a concern. So this particular article, really an interesting one. And does it apply to our practice? Well, in my mind, the question should always be, how does this apply to me? And you guys, the operational medics, did a really great job, I think, kicking me in the back a number of years ago at SOMA, because it was really, as a young AMED officer supporting you guys, it's kind of directionless. And somebody said, yeah, well, it's really easy. You just ask yourself, how does whatever you're doing support the operational soft medic out in the field? And that is a really easy mission set and guidance to take. So for this particular article that you chose, it is talking about hyperkalemia or high potassium in CPR. How does this apply to me? Well, all we've been talking about for GWAT for 20 years is trauma, which is a etiology of losing too much blood, or hypovolemia. And I think we all know, and it's been well documented, that trying to pump a heart that is empty of blood should essentially be considered futile. If your patient doesn't have a heartbeat because they've lost blood, then the answer is give them more blood. And oftentimes that heart will spontaneously resume function. But as a number of folks in the community keep foot stomping, something like 50 to 80% of people who are taken out of the fight, depending on the fight, are from disease non-battle injury. And so those are medical causes of injury, including CPR. So does medical CPR apply to you in your practice? I don't know. You think so?
I mean, is it futile? You're talking on the battlefield, bullets flying. Yes, it's futile. You don't have the time nor the stuff to focus on this. You're at camp, or you're at your base or FOB. There's no danger to spend some time, and some causes are reversible if you assess and attack your H's and T's. Ultimately, could it be futile and the patient passes? Yeah, it could, but you could win. And is it worth 20 minutes of sweat, a couple of vials of an easily acquired medication to use on this human being who's on your side. I think in that case, yeah, it's worth it.
Yeah, fair. So CPR is probably something we should keep in our armamentarium. Maybe not as much for trauma runs, but certainly for medical runs. And we're going to see hyperkalemia quite frequently. So since we've started this project, we're really trying to standardize how a medic can kind of learn from the PAs and the docs about how we approach reviewing an article. And one of the things that we really like to do is go through it from a PICO perspective for studies. So for this study, for the PICO, just like all of them, we're looking at the population that was studied, the interventions that were performed, the comparators to the intervention, and the outcome. And so we were just going over this before we started recording, but remind me, what was the population for this one?
The number or where? Like this was in Taiwan. I think all of the data sets are from Taiwan. I don't know enough about Taiwanese people to say they're drastically different than any other human being, but I kind of doubt it. So I guess, did that answer your question? Is that a trick question, Alex?
Ooh, now you're starting to get into the gray zone ops of medicine. I love that. Yeah, I think if I remember, it was a retrospective review it was that one tertiary trauma center, right? Like a 2,000 bed hospital in Taiwan. And they've got a pretty good data registry. So they found everybody who got CPR in that hospital. The intervention was those who were dosed with calcium and or sodium bicarbonate during CPR with a identified hyperkalemia event. And that was compared against those who just got usual care. And the outcome they were looking for was dead versus not dead. And I'm just realizing I missed a great opportunity to put in a GIF from Monty Python about bringing out your dead.
Yeah.
I'm not dead yet. And I will foot stomp in here just again in terms of increasing your armamentarium of knowledge. The outcome of dead versus not dead is a pretty crappy outcome in general, because again, it's a black and white outcome. And that was one of the frustrating things that a lot of us in healthcare and in the ICU ended up getting really annoyed about during the COVID pandemic is all we would hear every day is the number of decedents, which was terrible, catastrophic, heartbreaking for those whose family members were affected. But what it didn't take into account when you just talked about the number of dead every day was not the number that were critically ill, that potentially needed ventilators, that had long-term health injuries, that needed to be on oxygen for the rest of their life. And so in my mind, if you really want a good study outcome for a lot of studies that we look at, it shouldn't necessarily be death versus survival. Again, that's black and white. But instead, something that we've been looking at in trauma and especially in stroke outcomes since, if I remember, I think this came out in the 70s, 80s. And it's called the Modified Rankin Scale. Oh yeah, 1988. So Rankin was the doctor who first came up with this very objective, discrete criteria for neurological outcome. And it was really great because it's just like the GCS score almost, but for neurologic outcome. So, the great thing about GCS is you can just tell somebody they're an E4, V5, M5, and they know exactly what you're saying to somebody. Hopefully, if you remember your
at least
GCS
look at the
score.
picture, right?
Yeah, absolutely. And the modified Rankin is exactly the same way. So it really has nothing to do with this paper, but I would be remiss to not discuss this with folks. So you can see the modified Rankin goes from 0 to 6. And in particular, I really like these for neurologic events, whether it's a traumatic subarachnoid or just a thromboembolic stroke or even a hemorrhagic stroke. And fun side note, almost every single intervention, including most of the thrombolytics that we give people. The modified Rankin score at 6 months doesn't get changed with any of those interventions. You have the same functional outcome whether you get thrombolytics or not. But remember, if you give somebody a thrombolytic, you've got a 5% chance of giving them a catastrophic brain bleed, which will make them a modified Rankin 5. Right. And also, I mean, this is totally worth talking about with your family members and loved ones, because my wife knows exactly where I am on the modified Rankin scale, where I do not want to be recovered or resuscitated. And I think this would have been a much, much better criteria to use for this particular paper. Yeah. So anyway, just a little food for thought on studies and what a good outcome is versus a bad outcome. But going back to this paper that you picked out for us. So again, we're trying to make this easy for guys to digest. So the background for this is for 6 years, from 2006 to 2012, in one tertiary hospital in Taiwan, they were able to record all in-hospital CPR events and really look at the medications that were administered. So the methods, the original data set for IHCA is in-hospital cardiac arrest versus OHOCA, or the out-of-hospital cardiac arrest. About 1,100 patients. Only 100 of those had a potassium that was over 6.5. So you're only looking at 10% of those patients. Of those 109, you had 16 who did not get any medications. I didn't put that on there. 4 that just got calcium, 32 that got sodium bicarbonate, and 57 patients that got both of those medications. And for the results of this study, drum roll, 109 patients that had an in-hospital cardiac arrest event with a potassium over 6.5. 40 of them got ROSC, or return of spontaneous circulation. Unfortunately, it looks like about 2/3 of those expired before 24 hours. 90% of those who got ROSC died prior to hospital discharge. And of the patients who did get return of spontaneous circulation during CPR while having hyperkalemia or high potassium, one of them had a favorable neurological outcome. And again, I don't even know where on the modified Rankin they are arbitrarily defining favorable.
Yeah.
Yeah. I don't recall seeing that in the paper. Did you?
No. But I did have a couple questions. So, they mentioned this is a large data set. They're looking at over, was it 4 years? 4 years, they got a total of just over 1,000 people had cardiac arrest. And then they whittled that down incredibly quickly to, we're just looking at this 109. So, what number do they call a large data set?
Oh man, you really want to get nerdy? We can go nerdy. We can do that.
I can say Wake County has 5 million people, so this large data set, and then quickly go down to, whatever it is I want to look at.
Yeah, it's fair, and you can really get pretty dirty with data if you want to kind of sway it towards the outcome you want. So large data set is kind of gray in terms of who gets to define that and what that number is. Most of us would definitely consider single digits to be a very small data set. Double digits, not a great data set. Unfortunately, a lot of stuff gets published with those numbers. Triple digits, 100 to 1,000, maybe that's a good preliminary data set. Then you look at the CRASH 2 trial, which was the one that started us to use TXA for hemorrhagic trauma, which had 40,000 patients. And the unfortunate reality for that one is just like this post that kicked you off. So remember, CRASH 2 actually got leaked on social media and said it had a positive outcome. When folks ran the data on CRASH 2 that said TXA is helpful, No kidding. The original analysis of the data showed no improvement in outcome, and the authors actually had to issue a retraction on that. But once it hit social media, it kind of went around like wildfire, which is, I think, what you experienced with this posting as well when you were going through a lot of the comments, right?
Yeah. I mean, there's all kinds of comments, jumping on board with this, which kind of confused me because the comments happen within minutes. So I know nobody looked at anything. They just agreed, which I appreciate with my posts. Just agree with me really quickly. But it just makes me think maybe I'm practicing. There's a lot of information that I don't know, knowledge that I don't know. Am I being told essentially wrong? So in order to make sure that I'm doing right by my patients, being right by my students, that's what pushed me to sit down and read.
Yeah. Yeah, and it's interesting too, because I think a lot of folks will slam either or both of these medications, the calcium or the sodium bicarbonate, during CPR without really having an understanding about how they function physiologically or the mechanism of action. I'm guessing over at the JSOM TC, you guys are too task saturated to go into the biophysics of that.
I mean, we do at a pretty superficial level. Pretty superficial.
Yeah. So the way I like to think about it is calcium isn't actually going to do anything for your hyperkalemia. Your hyperkalemia or your high potassium just causes cardiac irritability, which can allow your heart to deteriorate into a non-perfusing rhythm, which is bad, I've heard.
Yeah.
But the good news is that it turns out, but calcium is a cardiac membrane stabilizer, so it theoretically is supposed to lessen the chances of deteriorating to a non-perfusing cardiac rhythm.
Yeah.
But again,
one of
calcium.
One of the other papers talked about that are referenced in this talks about the I don't know what kind of trial, a benchtop trial, but they looked at how does calcium work for the heart. And it actually does nothing to do with the concentration gradient. It has everything to do with speeding up conduction velocity. And that's at least how this paper says calcium worked.
That makes a ton of sense, actually. Yeah. That would be phase 0 of cardiac contractility, I think. Yeah, but to your point earlier, calcium actually does nothing to treat hyperkalemia. It just prevents you, hopefully, from dying. And then the sodium bicarbonate, which has a ton of sodium, hopefully can just improve your abysmal serum pH when you're in CPR, so that your medications can actually be functional. But in this particular paper, what we saw is they looked at, to your point, 1,100 people who had CPR, and one of them had a favorable neurologic outcome at time of discharge. That's a bummer.
Yeah. Well, I mean, I guess cardiac arrest, I guess, to just discharge, I would want to see, if you're having a heart attack in the hospital, my guess it wasn't the heart attack that brought you to the hospital. It was something else. Probably serious, because it made your heart stop. So there's got to be a lot of confounders. I've seen many, probably not to you many, but to me many, patients that just go into cardiac arrest and they bring them back, and then the next day they go into cardiac arrest and you bring them back until essentially the family tells them to stop. One doesn't surprise me, but there's got to be other confounders other than, did you give that guy calcium or not, or did you give that guy bicarb or not? They're not magic fairy dust. There's got to still have to fix the cause.
Yeah, you're not wrong. And I think if I remember in this article, they actually talked about how there was a discrepancy between the Taiwanese practice standards of generally like 1% survival from CPR versus in the US, it was about an 18% survival to CPR. So sorry, I didn't talk with you about our summary sheet ahead of time. But in looking at this one, this is oh man, I didn't update it. So this is actually a retrospective single center study. Still probably level 3 evidence. Pros of this one, is it a large data set? I don't know. I think I might actually, even though they self-identify as a large data set, I don't know if this is a large data set, to be honest. And it's single center and it's retrospective. It certainly does have application to DNBI, to your point. There's a lot of medical causes of requiring CPR. And the pro of this data set is obviously at this over 2,000 bed hospital. Holy smokes. They had rapid access to point of care testing during CPR, so they could actually collect that good data. You've definitely foot stomped on multiple confounders. What else do you think might be some weaknesses from this article?
I mean, you could talk about, and they mentioned in the paper, the quality of the CPR. How badly did they really want this guy to live? What is the cause of the original cardiac arrest? Time to when the patient's alarm goes off, how long did it take for the nurses and the staff and the cardiac team to get in to actually start doing CPR? So I think there's, just like anything, it's a very dynamic environment, and there's a lot of things that can go into it that have absolutely nothing to do with what is their calcium level or sodium bicarb deficiency.
Mm-hmm. Yeah. And I also don't see that they actually did any power analysis or sample size calculator. So it's just kind of a stab in the dark for an article that's 9 years old.
Right. But I mean, like you mentioned that, like, resuscitation is not a small journal, I don't think. Like there's a bunch of confounders and there's a bunch of things like, they probably should have added. You know what I mean? Like if I had my own journal, this would get through 100%. Like, look at doctor. Let's print it. You would think a medical journal like resuscitation or trauma or something like that would kind of go through these.
One would hope. Yeah. And so let's see. I was also interested in seeing if folks, if they wanted a better understanding of hyperkalemia. I know you guys do a pretty darn good job of going through the JTS CPGs. So not to put you on the spot too much, but legitimately one of my favorite ones is the hyperkalemia one, because I've actually had to use it downrange, which is terrifying. But do you guys go through this much at all in your clinical practice?
We pretty much most of the time we talk about crush with hyperkalemia, not hyperkalemia on its own. Okay.
And so educate me then, being that you are the guy who is teaching other folks about this. When you've got a patient who is meets the inclusion criteria for being concerned about hyperkalemia because they went through a crush event, what are you looking for signs and symptoms, both with your physical exam and then with diagnostic testing, to make you concerned about somebody who might be going into hyperkalemia?
First, MOI, like his leg is flat. That's a big tip off. And then at least something that I would look for is abnormally, I guess, a bradycardia that makes zero sense. He's got a bunch of reasons to be tachycardic, but for some reason his heart rate is, 60 or 50, and it's not because of all the pain control that I've been giving him. That would be a great big tip off, that without some kind of EKG or, even just a personal, like, one lead type thing. That would be my first tip off, would be the bradycardia, relative bradycardia.
Yeah. Yeah, good one. And no, man, I'm not going to tell you you're wrong. No, but I was hoping you were going to say something about the peak T waves, because I think that was in the social media post that got you on this diatribe. And what's really unfortunate is that is one of those wives' tales that has been talked about forever. But unfortunately, the reality when you work in the ICU day in and day out, and this has been published numerous times, is an absence of those peak to T waves does not mean you're in the safe zone.
Yes.
Right? Yeah. And there's a lot of guys who will hang their head on that and say, "Oh, we're good, man. There's no peak T waves, no big deal." And the next minute, that dude can go into a non-perfusing rhythm.
Oh yeah, yeah. You cannot mention the word hyperkalemia without also mentioning peak T waves, or you will be removed. But
it's like a Pavlovian response.
I think I did read something about it. It happens maybe 25% of the time. But the point being, not necessarily how big or small the percentage is just understanding, like, it doesn't have to do that. You need to assess your patient. What will happen is that bradycardia, and they can be cruising along just fine, and then they go into VFib. It can literally do any of the things.
Which is terrifying. Yeah. And there's a great adage in medicine that we always teach people to understand these, like classic presentations. And across medicine, you tend to find that in general, a patient will present with those classic signs about 15% of the time, no matter what the disease is. But then we reassure ourselves and say, "Oh, we didn't see this presentation, so it must not be that." And that's not true, man. And so interesting little mind journey here. The Joint Trauma System clinical practice guidelines on hyperkalemia in the deployed setting, including indications for initiating dialysis, which is really important, have here that you need to start being very concerned with a potassium over 6.5 and provide some exogenous treatment modalities to stabilize your patient and try and reverse the process. Interesting to me that they their first line is obviously the calcium to stabilize the heart, hopefully, so that you buy yourself some time, and then do the insulin to shift that potassium back into the intercellular space, which was not discussed in this paper at all. But what I was going to say instead is, if I can get back there, the paper, do you remember how high the potassium was that they were looking at? Because I remember being shocked.
Yeah, but let me look it up quick.
Yeah, because they had different in their multivariate regression analysis. They looked at different categories of patients.
Let's see.
Here it is. Found it. Cool. Table 3.
Okay.
Yeah, so table 3 up here on the screen, they looked at different tranches of potassium levels to determine if some particular group of patients would do better with the interventions. And for those patients who had a potassium level over 6.5, so you can see they started at this critical level. None of these folks did well. And then when you look at the 6.5 to 7.9, holy smokes, they did even worse. And then 7.9 to 9.4, you essentially have very few people who are surviving. And then over 9.4. And, again, to your point about why was this paper published, in the resuscitation bay or in the ICU, if we would get a potassium level of 9.4 back, that is generally considered incompatible with life. And so this is a study that some might consider was essentially looking at what might almost be non-survivable patients and then gave them that calcium and bicarbonate, and then they still didn't survive. To your point earlier, is that really going to change your practice about giving sodium and calcium during CPR?
I mean, I have the luxury of not having labs, so I'm not burdened with numbers like this. But I don't know how fast the potassium level can go. Hyperkalemia can be caused during cardiac arrest, but I would imagine you're talking a long CPR to get to 9. I would imagine it's a long CPR to get to 8. And the criteria just starts off at 6.5. I know you should be treating 6 or higher. You should be doing something about it. So I mean, if I would imagine if you're doing CPR that long, or they're that far off, you're not going to win just by giving some calcium or giving some bicarb. Like, they need probably, I don't even know what they need. They need bypass. They need a new heart.
Yeah. It is unfortunate. So yeah, and for those who may or may not remember their pathophysiology, the reason that we get that potassium buildup within the serum is that historically, when your body's functioning well, about 98% of your potassium is within the intracellular space, and only about 2% of your total body potassium is circulating in your blood supply. But when your body stops functioning, and therefore your cells and your ion pumps stop functioning, you stop moving that potassium in and out as those muscles activate. And so that potassium just ends up accumulating within your circulating volume. So it's essentially a surrogate marker to your point about how long you've been down for. And so I don't really think in many ways it's the potassium that's the be-all end-all, except for cardiac irritability. It's really just that is telling you that this person has already been down and is very sick for an extended period of time. But to your point, if this is one of my buddies on the team, even if I don't think it's going to work, I'm still going to do it.
Oh, yeah. I mean, why not? I mean, assuming that, the enemy or the elements or whatever it is not making this dangerous to stay here and play, yeah, we're doing it. It might be fruitless at the bare minimum. I'm trying to save my own self-worth and psyche and that of my teammates to know that I'm doing absolutely everything I can.
Yeah. Well, this is a good one. I'm glad you teased out, not necessarily because we love the quality of the article, but I'll tell you, I am super excited that you saw a social media post that you disagreed with and you tugged at that string, which is what I love about special operations medics. You did a great job tugging at that string and found what they argued was their underlying supporting evidence. And in going through it today, I don't know that this particular article that they said justifies their position. I don't really know that it's a great article to use to support their decision, but there's probably not a lot of folks that went out.
Like most of these articles comes out like more research should be done. Like, well, not if this is what you come up with. Yeah.
Their conclusion was the use of calcium and sodium bicarbonate might be effective in the treatment of severe hyperkalemia during cardiac arrest. The efficacy of calcium and sodium bicarbonate correlated with serum potassium level. So they're saying The worse your potassium level, the less effective it is. However, because the number of patients included in the analysis was small, this conclusion should be further examined in the future. Yeah. So no dig on them. They did a really nice job designing this study. It just didn't answer, in my mind, a super helpful clinical question, because I think these patients had a very poor chance of any meaningful outcome by the time of enrollment.
Yeah. And I think, just making the leap from, kind of a very soft statement, I guess, that it can kind of work if they're not sick enough or they're not too sick, to go from that to it doesn't work. It can be pretty dangerous, because not everybody is willing to put in that work. And, when you have letters after your name, people just take it on face value that you did the work, and now you're telling me what you think.
Yeah, fair enough. Man, I think my uncle gave me a button years ago, and it said something about seek those who know the truth and be wary of those who have it. Which I think is a pretty great adage for doctors.
Yeah. Yep, absolutely. Cool. Well, I know you're really tired, Alex, so I'm going to let you get back to your rest. I really appreciate you coming on.
Yeah, this is fun. Hopefully we can get some more nominations for interesting articles to drill and dig down into. We take stuff that's hot off the press. We're trying to look through the Journal of Trauma as time allows. Journal Pre-Hospital and Emergency Medicine is pretty great. Wilderness Medicine. If you are thumbing through any of those or other journals and you see an article that you want to chat with us about, hit us up.
Yeah, I would definitely appreciate it. Cool.
Till next time, brother.
Till next time. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge.
I just realized I forgot to let you use your 3D printed scale.
Out.